My presentation was on discussion regarding biology of aggressive disease. Now, aggressive disease is defined as those patients with myeloma whose survival is predicted to be 2 years or less. So despite all these new drugs, the response may not be as good and they do not survive very long. And we and others have a lot of investigation to understand why this group of myeloma have adverse outcome very quickly. Over the years, number of methods have been developed to define what would be aggressive disease. Originally, we had this ISS staging system, but it did not have cytogenetics and FISH data included. And when we have FISH data, if ISS may not be there. So more recent change was what is called revised ISS, in which the aggressive myeloma or high-risk myeloma is defined as patients with ISS stage 3 with addition of either high LDH or abnormal cytogenetics, basically 414 translocation or 17p deletion. Now, this has been improved upon by some of the newer technologies. So we have expression profile where we have the 92 and 72 and other gene signature. That hasn't made as big a difference as now the newer investigation with whole genome and transcriptome sequencing, where we now find mutations. Now, no specific mutation suggests a high-risk disease. However, if there are more mutation, those patients have high-risk disease. And so the bottom line is that anyone with more than 2 chromosomal changes or mutation should be considered as a high-risk disease. This constitutes around 10% of the patient. And very recent, from last ASH, some of our data using larger data sets suggest that if there are 2 occurrences together, and the 2 specifics are that patient with 17p deletion has p53 mutation, both together, that's an ultra-high-risk disease. Or if patient is ISS stage 3, but has 1q amplification together with it, that's an ultra-high-risk disease. Considered around 5 to 6% of the patient, their survival with all the new treatment is still less than 2 years. So one of the things I discussed that after defining what is high risk, the important question is what causes the high risk. And the bottom line is that if myeloma genome is unstable, that myeloma would end up being high risk if it is already not high risk. And so instability of the genome drives the risk in myeloma. And then we discuss about some of the processes which may cause the unstable genome. So abnormal homologous recombination, elevated nuclease activity, and more importantly, ApoBec upregulation. These are the processes or the biology that drives high-risk phenotype. And so we are beginning to understand that, developing tests for that, so that instead of doing all these other things, we can now focus on identifying the mechanism of high risk. And in final conclusion, instead of our doing sequencing for mutations and cytogenetics and FISH and copy number, we have now a test where using around 3 megabases of sequencing, we can do all this with one test. So we can look at mutations, we can look at copy number changes, we can look at translocations, and then come up with more clear risk stratification in one test. And this is sort of targeted sequencing, which is probably going to replace some of the stuff we do. But the main focus is that we know which patients at the moment have high risk, and discussion for tomorrow literally in our meeting is going to be how do we treat this high risk patient? Do we treat them differently or not?